Assalamu alaikum wa rahmatullahi wa barakatuh. Today, inshallah, we will talk about one of compatibility tests that should be done for both donors and recipients, which is antibody screening test. So the main points that we will cover today will be the aim of this test. So we will discuss the aim of the test, the importance of doing this test for both donors and recipients, the principle of this test, red blood cell reagents used, antigram, dosage effects of different antigen. We will talk about methods that we can do to do antibody screening test, but we will focus mainly about tube methods. Finally, we will discuss some results of antibody screening test. So let's start. Antibody can be divided into two parts, expected antibody and unexpected antibody. In antibody screening test, the main aim of doing this test is to detect unexpected antibody. The unexpected antibodies can be divided into four categories. First one, and the most important one in transfusion, is the immune allo antibody. So we mean by this category is the antibody produced against red blood cell antigen, foreign red blood cell antigen, when the body is exposed to this antigen. The second one is the passive antibody. So passive antibody is the antibody produced in one individual, then transferred to another one. So for example, in newborn, the antibody we found usually in newborn is a result from passive immunity. The antibody actually present in the mother, but then it is transfused to the newborn or to the fetus by when it's passed through the placenta. The other category, the third one, is the auto antibody. So in case of autoantibody, the immune system will start to reduce antibody against self-antigen. And finally, the naturally occurring antibody. Naturally occurring antibody is very rare. Its naturally occurring antibody other than ABO is very rare. So here in this case, the body will produce antibody against red blood cell antigen. But in this case, the main reason of producing this antibody is not because the antibody, the patient or the person exposed to foreign red blood cell antigen. No, in this case, it's produced against antigen other than red blood cell antigen, but the structure is very similar. So again, the main aim is to detect an unexpected antibody, not the expected one, which is anti-A and anti-B antibody. So in ABO antibodies, we already detect them when we do ABO testing, if you remember. So you come back and see the video when we discuss ABO test. So here we are looking for unexpected antibody, and the most important things is to detect the immune allo antibody. However, it's expected if we do antibody screening test, we may detect any of these antibody, but again, the most important one is this one. Now we will talk about the importance of this test. So it can be done for recipients, or usually we do not for recipients, but also for donors. So in case of recipients, we want to detect, as we said, unexpected antibody. So at this level or at this test, we just want to know if the patient have unexpected antibody. So if the test is positive, that means we have to continue and to do antibody identification test to identify the specificity of these antibody. So here in this test, we will just detect it, but we will not be able to know what's the specificity of these antibodies. So we will not be able to know, for example, if the antibody present in this patient is anti-A or anti-kill or whatever. So we just know that there are unexpected antibody present. So when it's positive, we have to continue and do antibody identification test, and we will discuss this test in another video. If it's negative, there are no need to do an antibody identification because there are no antibody detected in the recipients. In donor, we have to do, in many countries, we do, in blood banks, they do antibody screening tests. So if a donor, and this is very rare happen, if a donor have an expected antibody, the donation is discarded because we don't want to use plasma contain unexpected antibody because these antibodies can cause complication in recipients. So for recipients and also for donors, however, even if we detected, yes, we will discard the donation, but there are no need to do antibody identification for donors. Pregnant women, also it's a part of a prenatal test. So when pregnant women come at first trimester, usually we do antibody ABO typing, we do RHD typing, also we do an antibody screening. And in another video, we will discuss in details the prenatal tests that's routinely done for a pregnant woman. So again, here it's important to determine the type of the antibody present if in pregnant women. Also, it's very important to determine also the level or the titer of the antibody because we have to monitor pregnant women with antibody because these unexpected antibody can cause hemolytic disease of a newborn. The main aim of this test is to detect antibody. So because we want to know if a patient or donor have antibody, we will take the serum of the donor of the patient. So the antibody is unknown. So we want to know if she or he have it or no. So if antibody is in unknown, we have to add reagent which is able to detect presence of this unknown protein. So here in this case, we have to add antigen that we know the specificity of these antigens. So in this case, the sample is serum or plasma, and the reagent is antibody. Sorry, the reagent is a red blood cell. So red blood cells. So we have to add the antibody reagent, the red blood cell reagent to the serum, then incubate them together. So if the antibody is present, it will bind to the red blood cell. So if it's bind, it will sensitize the red blood cells. However, in this case, we will not be able to see the reaction because in sensitization step, there are no bridges formed between cells. So in order to have these, we have to add enhancement reagent. So because most of the clinically significant antibody present and we are looking for it in our sample is antibody from IgG class. So these type of antibodies incomplete, so it not be able to cause direct agglutination because the IgG, as we discussed in different video, is quite small and it cannot cross the zeta potential, the distance between two red blood cells, which is formed as a result of negative charge of the red blood cells. So we will not be able to detect that. In order to have agglutination, we have to add enhancement media, and in this case, we have to add Coombs test. So in Coombs test, we have to do Coombs test in we have to add Coombs reagent. Coombs reagent is antibody. So it has the ability, so it's antibody, so it has the ability to bind human antibody. So in this case, it will be able to form bridges between cells because let's draw This is antibody. So anti-antibody will be binded. So as we can see in this example, so it can form bridges between cells. So as we can see here in this example, the Combs reagent able to cause bridges between cells. So we will be able to detect, which is indicate the presence of the low antibody. So the main principle used here is the indirect antiglobulin test. Indirect antiglobulin test. As we said, we have to use red blood cell reagent with known antigen to detect the unknown antibody. So usually we use 2 or 3 screening cells. So a panel consists of 2 cells or a panel consists of 3 cells, and these cells should be from O type. It should not be from A type or from B type, because we don't want to detect anti-A or anti-B. We want to exclude these antibodies because these as expected antibodies, and as we said before, we detected in the ABO typing test. So the main aim here is to detect other antibodies. So this is why we must use screening cell from O type. These screening cells will expect different antibody, will express different antigen. The most they have to expect to express the most important clinically significant antigen. So the importance of antigen is come from the importance of the corresponding antibody to these antigens. So we consider antibodies as a clinically significant antibody when this antibody have the ability to reduce the lifespan of the red blood cell. And sometimes antibody reduce the lifespan from 120 days into only a few hours, or sometimes even less than that. So these screening cells must express the most clinically significant antigens, which are these 5 antigens from Rh, big C, little c, big E, little e, so these from Rh system, the big K and little k from Cal system, Duffy A and Duffy B from Duffy system, JKA and JKB from KET system, Lewis A and Lewis B from Lewis, and P1 from P1 PK system, and MN big S little s from MNS system. So these considered are the most clinically significant antigens. So all of these antigens have to be expressed on these 2 or 3 screening cells. They have to be expressed homozygotally between them, and we will explain what I mean by homozygotally between them now. So before that, let's see the antigen profile or the antigram. So we can see here in this antibody screening test, 3 cells are used. 3 cells are used. So in cell number 1, we can see the antigen expressed on these cells. So this is commercially available kit, and the antigen profile come with the kit. So here in this kit, or in this example, we can see in cell number 1 there are a number of antigen expressed. So if it's positive, that means the antigen is present. If it's 0, that means this antigen is absent. So let's see cell number 1. So here the antigen is present, big C, but not little c or big E, little e, and small k. And this is other antigens from kill system. This is not mandatory to be present in cells, but here in this panel, these antigens is also phenotyped. So Duffy, both of them, is present. الكد here كد A and here Lewis A P1 and here MNS big S and little S and Lutheran also XG antigen. So all of these antigens present and the one with 0 is absent. Number 2 is quite different. So here D is present, little c, big E, both of them, LK is present, and so on. Okay, so we will discuss it now, and also we will discuss the panel again when we talk about antibody identification test. So this panel or this sheet is used for one patient. So the result is recorded here. So if it's the, we will add these cells to patient serum in a separate tube and the cell 1 and cell 2 and cell 3. So we will have 3 tubes in this test. So for example, if it's give positive here and negative here and negative here, that means the antibody screening is positive, even if it's reacts with only one cell. And we will discuss the phases now and we will understand what phases mean. Before that, we want to understand what is the dosage effect. So we just say that in red blood cell reagent, the clinically significant antigen should be expressed on the cell, on the screening cells homozygotally between them. So, for example, here in cell number 1, we can see, so these two, let's see the antithetical antigen. So antithetical antigens means one of them at least must be present. One of them at least must be present, or it's not must be present, but usually one of them is present. It depends. Sometimes it's a must be present, like in case of big C and little c, but sometimes both of them is absent, like in Duffy antigen. So here, big C and little c are antithetical antigen, LE, and small e, big K and little k, here LA and B. So these are antithetical antigens. Okay, so let's see now which are homozygically expressed and which are heterozygote expressed. So we can see here only the big C is expressed. So that means this cell is homozygotally, the big C is homozygotally expressed on this cell. Also here we can see on the same cells the small k is homozygotally expressed on this cell. Okay, let's look now to a Duffy. So in case, so here it's homozygote for big C and homozygote for small k. But here it's heterozygote expression because Duffy A and Duffy B both is present at the same cell. Both present at the same cell. So if the antigen is homozygotally expressed like in big C here, that means the number of big C copies is very high compared with heterozygote expression. So if a cell have only big C, that means there are too much copies in the cells. So usually in red blood cells, we don't have only one copies of antigen. No, we have thousands of these copies sometimes. So if it's homozygote, that means too much of that copy present on the cell. And here, so for example, here the big C is, there are too much of big C and the cells. Here also the small k is the number of copies is very high of small k. However, in this cells, Duffy A and Duffy B, both of them is present. So the number of, for example, copy of Duffy B is lower than the cells which is only homozygote for Duffy. Let's see for here. So if we compare it with cell number 2, cell number 2 is homozygote for Duffy A. So in this case, the number of copies, so both of them have Duffy A, isn't it? But the number of copies in cell number 2 is much higher than the one present on cell number 1. So what's the importance of that? So how the number of copies can affect. So as we said before, it's important to express these clinically significant antigen homozygotally between them. So in this kit, this is a quite good kit because we can see, for example, in Duffy, it's expressed homozygotally between cell uh, 2 and cell 3. So here it's homozygote for Duffy A, but here it's homozygote for Duffy B. So it's quite good here. Also for kid A, it's a homozygote for kid A, and here for kid B. So they express these antigen homozygotally between them. So this is quite good. So why it's important? Uh, why this point is very important? Because sometimes, for example, if we have some of the antibody show dosage effect. So they will react with cell homozygote cells, but sometimes they may not react with a heterozygote cell. So for example, if so let's have this example. So here we have, let's see the patient have anti um, JKA. So this, the patient may react with this cells and have a positive, for example, 3, and here 0, okay, and here maybe 0 again. Why it's 0 again here and the antigen is present? Because it's heterozygote expression, so the number of JKA antigen is quite low. So it may give, we may miss the reaction. And if you don't understand it, don't worry, we will discuss it in more details and again in antibody identification test. So here we just want to have an idea about homozygote expression and heterozygote expression, and just idea about the importance of these uh, uh, point. Let's move now and talk about methods that we can use to detect antibody in a patient serum. So we can uh, we can use a tube method, which is the classical method. We can use gel technology, and we can use solid phase technology. We will discuss these two techniques in another video, and today we will focus on the tube method. So if you remember, we said that we need to take the patient serum, then we add patient. So this is the patient, this is the sample, the serum, and so in tube method, we will take a sample from serum and we take some of the red blood cell reagent, then incubate them together as we explain the principle. So we incubate them together. So we mix them together first. So we can do 3 phases when we do tube test. So immediate spin phase, that we just add a serum sample from the serum, then add some of the red blood cell reagent, then centrifuge them, then record the result immediately. So we call this phase immediate spin phase. So in this case, if it's positive, this is indicator that the antibody present in the serum is from IgM, because there are no incubation time and there are no enhancement media. So why it's agglutinate? That means the antibody presents from IgM, which is complete antibody and can cause direct agglutination. So after immediate spin, we have to record the result. Then we can continue and do the second phase, which is add the list, for example, here. So a list is a low ion extrinsic saline solution. It's enhancement media. We can add it also to the reaction and incubate at 37 for 15 to 30 minutes. Then do centrifuge and record the result. So here, if it's become positive, so sometimes it's negative immediate spin, then after incubation and add list is turned to positive. So here in this case, it will be not clear if it's from IgM type or from IgG type. There are very rare type of IgG can cause agglutination at this level, and sometimes it's from IgM, and it just need a little bit incubation time. Then this is why it's become positive after incubation for a little bit of time. So after that, we must do the indirect antiglobulin phase, or indirect antiglobulin test when we use the Combs reagent. This is the mandatory one. So there are no. It's not important to do an immediate span, and many blood bank centers they omitted this step because it's lead to detect IgM, which may present in patient serum, but it's not clinically significant. So sometimes they just omit this phase, and they don't also do a 37 phase. Directly do the immediate, the mandatory one, which is the indirect antiglobulin test. So they add a serum under the red blood cell reagent, incubate them, wash them, then add after incubation, they add a Combs serum. So if the unexpected antibody present, the antibody or anti-human antibody will cause agglutination. So we call this indirect antiglobulin test. So this is the mandatory one. Result of the antiglobulin test. As we said before, if it's positive with any cell 1, 2, or 3, if it's positive, that means the antibody screening test is positive. So in any phase, in immediate span of 37 or indirect antiglobulin phase, that means it's positive. And we will see now the importance of each phase. Sometimes we run autologous control together with antibody screening test. Autologous control, that means we will use patient serum and patient cells together. So we will incubate them together and add the enhancement media to the reaction. To understand the result, we have to ask these questions. So, in which phase the reactivity was? Is it an immediate span? So, if it's at this phase, that means it's from IgM, because as we said, it can cause direct agglutination without the need for incubation time and enhancement media. If it's at indirect antiglobulin test, that means it's from IgG type, sorry. So because IgG type, it will not react at immediate span because it's need enhancement media, and also it's need incubation time. So it will the phase will help us to determine the class of the antibody. Also, we have to look to the autologous control. So if it's positive or it's negative. So if it's positive, that means there are it may be a low antibody or it may be autoantibody. It's we have to back and see the transfusion history of this patient. Also, we have to back and know what's the disease if the patient have sometimes if the patient have a disease such as myeloma, for example, because sometimes some types of disease can affect the result, and it can lead to produce autoantibody. Number of reacted cells. So as we said, maybe two, we may use two screening cell or three screening cell. So if it's only one cell, the patient may have only one or a single antibody. If both of cells or all of the cells, the three cells are positive, that means the patient it's not sure or 100% the patient have more than that. But this is indicator if it's more than one cells is positive, this is indicator that patient may have multiple antibody. Let's see these examples and discuss it together. So in first example, the cell 1 is negative, cell 2 is positive, and the autologous control is negative. Okay, so only one cell is positive. Let's see the phases. So immediate span is negative, 37 is also negative. The indirect antiglobulin test is negative. Okay, so we have also to look to the other cells. So here, the immediate span 37 is negative, but however here is positive. So because it's negative at immediate span and positive here, this is indicator that the class of antibody is from IgG type because it's only react at this phase. So the question now is it a low antibody or auto antibody? Let's see the autologous control. So the autologous control, it's negative in all phases, so that means it's negative. So this is indicator that antibody is a low antibody, so it's not auto antibody, and it's from IgG type. So both of them, autologous result and screening cell result, help us to determine if the antibody is a low or auto. Let's see the other example. So here we understand that. Let's move and other cells. Another example. So here cell 1 is positive, the reactivity at two phases, the 37 and indirect phase, and cell 2 is again is positive here, and the autologous control is negative. So first things from autologous control that we immediately can determine this is not auto antibody, so it's a low antibody. And because it reacts in both cells, so maybe it's not only one antibody, maybe multiple antibody, and it may be from IgG type because it's not react at immediate span. So this is the possibility. However, as we said, we have to do antibody identification to do more investigation. Another example here, cell 1 is positive at immediate span, cell 2 also positive, but autoantibody is negative, so it's not auto, it's a low antibody. And because two cells react, maybe it's multiple antibody, and because so it's multiple, and because it's positive at immediate span, this is indicator it's from IgM type, so it's multiple. Here cell 1 is positive at this phase and also the other phase. Cell 2 again it's positive in all of the three phases. The autologous is negative, so it's not auto antibody, it's a low antibody. So it may be multiple antibody because it reacts with more than one cell. It's expected to be IgM, and maybe some of them is it's IgM, and maybe some of them is also IgG because it's also positive at indirect phase. Okay. Example 5, again we have it's positive here and it's positive here, and this is negative, so it's a low antibody. And it's positive. Same strength, we can see it here. So have a different strength. So like in previous example here, this is may indicator of presence of multiple antibody, and also it's indicator of dosage effect. Because for example, maybe the cell here, let's just remove this. So maybe the cell here is heterozygote, right? So cell 1, so because it's only +1, so maybe here the antigen is heterozygote, but here it's quite strong, gives a stronger reaction because it's homozygote expression. So this is why there are variation on the strength. So um, so variation in strength can be a result of presence of multiple antibody, or it may be single antibody, but due to dosage effect. Okay, so because here is the same strength, so it may be, or the most expected, it to be a single antibody. In example number, so it's a low and single, and so it's a low single antibody, and from IG, so it's from and from IgG type. Um, Here it's quite different. So here it's plus 3 and here also plus 3. So cell number 1 and 2. But the important point here, it's autologous control is also plus 3. So if autologous control is positive, we have to back to the history of the patient. Is there a recent transfusion? So if it's there are recent transfusion less than 3 months, these may be due to hemolytic transfusion reaction. So the patient antibody may react with donor cells, but if there are no recent transfusion, this is may due to presence of auto antibody. So we come back to patient cells. So sorry, we can back to patient history and see if the patient have certain antibody, certain disease like myeloma, multiple myeloma, or no. We can also look to the strength of the reaction. We can see all of them have the same strength, and this is another indicator of present autoantibody, because autoantibody usually cause pan-agglutination. So also if we test it against more cells, it may give the same reaction. So this is indicator again of present of autoantibody. So we discussed number of examples of results that we can encounter with when we do antibody screening test, and we understand the principle of the test, importance, and the reagent that we have to use it in order to do this test. So I hope you understand it, and if you still don't understand the angiogram and the different phases, we will discuss it again inshallah in another video in antibody identification test. So don't forget to subscribe and write a comment if you have any question of, or if you want us to explain any different topic.